Everyone. We're just seeing some more participants come in, so we'll hold off just for a moment for the formal introductions. Good morning, everyone. I'm Steve Broach, KC, and I'm here with my colleague, Nyasha Weinberg, and we have an hour this morning for this 39 Essex Chambers webinar to look at the future of the NHS in England, following the announcement in March that NHS England would be abolished. So we're going to run this webinar as something of a Q&A, where I'm going to be asking Nyasha some of the key questions that we've identified, and we would very much welcome questions and comments from the virtual floor as well. You should, I'm sure, now all be familiar with the Q&A button on the Zoom webinar function. Please do use that to pose any questions to us. I see one has come in, or something has come in already. That's excellent. Yes, the session is being recorded, I'm pleased to say, and will be shared via our usual platforms after the event as well. So NHS England, of course, the central body for the NHS in England after the Lansley reforms. I'm going to start by asking Nyasha to just explain a little bit about what NHS England is and what it has done for its relatively short existence.
Brilliant. Thank you very much, Steve. And good morning to everybody, and thank you for joining. So NHSE, or NHS England, as it is alternatively referred to, is an executive, non-departmental public body that leads the National Health Service in England. It's responsible for a wide range of functions, including oversight of the NHS budget, planning for the NHS, delivery of some NHS functions, including digital and education after the absorption of Health Education England, day-to-day operations. And the intention of NHS England was that it would be an arm's length body separate to the Department of Health and Social Care, with a focus on promoting high quality health and care. But it's been abolished.
Yes. So can you tell us a little bit about that decision, please? How and when is NHS England to be abolished?
Yes, so NHS England is set to be abolished, and that decision was announced by Sir Keir Starmer on the 13th of March 2025. It's part of a wider governmental initiative which is about NHS reform and freeing up funds to improve delivery of frontline services to patients on the ground. The intention that we know so far is for the management of the NHS to be returned to the Department of Health and Social Care, which has to date been running in parallel with high-level strategic oversight of the NHS's functions, but distinct from more of the operational policy delivery, which NHS England has been responsible for. That shift back from NHS England, the arm's length body, back into the Department of Health and Social Care will largely reverse the top-down reorganisation which was imposed by Sir Andrew Lansley in 2012 under the Health and Social Care Act 2012, also known as the Lansley Reforms. The intention behind the reform is to eliminate duplication. There's a sense that having both NHS England and the Department of Health and Social Care making decisions about the NHS at the centre of government will allow better resource allocation, ensuring that there aren't two bodies, slowing down the ability of the cogs to whir, and therefore enabling the resources that come from taxpayer money to be directed to frontline services, or at least that's the hope. Steve, you asked me about the timeline. We've been told 2 years. How long 2 years is kind of remains to be seen. It could be 2 short years or 2 very long years. But also the plan for exactly how the transformation will take place, and whether some functions will move into DHSC quickly or slowly, and the ordering of those all remains kind of unknown territory as from where we stand. The Department of Health and Social Care always had strategic responsibility for setting goals and oversight of NHSE accountability. Whereas in comparison, NHS England negotiated the budgets for local care provision with the integrated care boards, which are the local delivery boards for the NHS and for hospitals. And it did performance management, such as monitoring waiting times and quality measures and implementing national initiatives across the NHS. The Department of Health and Social Care staff conventionally had broader policy expertise, so we're looking at whole areas in the round and strategic oversight, whereas NHSE staff, the hope was that they had more insight into what was happening on the ground. What has happened historically is NHSE and DHSC has worked together on some issues, but sometimes they've pulled in different directions. And it became increasingly clear to the politicians that have now made the decision to separate, to rejoin the two organisations, why they were separate or why it was necessary to have both. One thing which Steve and I will probably discuss over the course of the next hour or so is the fact that we don't know exactly which functions are going where and whether all of them will be restored to the Department of Health and Social Care, or whether there will be a devolved aspect to this, with some of the functions going down to the integrated care boards in order to hopefully facilitate greater responsiveness to local needs, which was the reason for the establishment of the integrated care boards in the first instance. Steve, I'm sure you'll agree this comes at a really challenging time for the NHS.
Absolutely. And one of the big things that was announced alongside the abolition of NHS England, of course, was a 50% reduction in ICB budgets. And there is a risk, I think, that the top-down change obscures the very significant challenge, to use an enormous euphemism, that that's going to cause for the local NHS. It doesn't seem to me that most ICBs are running with 50% surplus capacity at present. And the idea that we can cut ICB budgets by 50% and not impact on patient care seems wildly optimistic. Would you agree?
Yeah, I think wildly optimistic. And then you add in a changing demography of the country, which means that there are more older people and rising demand for care, a changing kind of geography of illness and incidence of illness, which actually, again, increases the demand for care, and also the acknowledged need that services really need to be transformed to function better, which links back to what the government has said about the need to introduce things like AI into the services, but also to resolve long-standing staff issues, which were the subject of so many strikes over the course of the last few years.
Absolutely. So as usual, a complex and multifactorial picture. We can assume, though, I think it's fair to say that this is going to happen, because although primary legislation will be required to effect the abolition of NHS England, given the size of the government's majority, it's reasonable to proceed on the basis it's going to go through, isn't it? So perhaps we need to move and look at what comes next as far as we know. And what do we know yet about, is it going to be a straightforward absorption of NHS England's functions into the department, or might there be a more complex and nuanced transition, do we think?
So the first thing that we've had is the appointment of a transformation team. And that transformation team is going to be led by NHS England's transition chief executive, Sir Jim Mackey. And he's going to be overseeing this organisational shift. What has been announced so far and confirmed by Wes Streeting in Parliament is that functions such as digital services, cybersecurity, which is obviously essential given the confidentiality of patient data, which is held by NHS, by the NHS in general, and specialist commissioning will be transferred to the Department of Health and Social Care. There is also the upcoming 10-year NHS plan. The details of that plan remain unspecified, but the intention, as announced by the politicians, is to ensure that the reintegration back into Department of Social Care and the 10-year plan will all work together in concert to create a kind of future strategic vision for the NHS. As Steve said, the announcement also said that strengthening integrated care boards will take place, but what strengthening means at the same time as halving resources remains unclear. The local management and tailoring of healthcare to regional needs is something which is intended, but there will be a significant number of functions which remain at the centre to try and avoid the postcode lottery type issues that come about with ICBs kind of running at very different levels. I think the other thing that has been announced, which obviously from a legal perspective means that there may well be a significant number of changes coming down the track, is the fact that there will be a streamlining of regulation in the process. So it's an opportunity to review all of the contents of the Health and Social Care Act 2012 and consider how those might need to be modernised or updated or adjusted for the world of 2025.
So within that mix, one of the issues that I think is perhaps most interesting legally is, of course, NHS England's specialist commissioning function. When we were looking at the case law, it's notable that quite a large amount of the cases involving NHS England involve that specialist commissioning function, whether that's services like the gender identity services, where, of course, litigation went to the Court of Appeal relatively recently, or specialist commissioning of medication for very rare conditions. What do we think is likely to be the implications of that function, specialist commissioning, going back to the department? We can assume it will do, with the Secretary of State now being directly responsible as opposed to the arm's length body. How do you see that playing out?
Yeah, it's a really interesting question. From a commissioning perspective, one example of a judicial review which was brought against NHS England was the British Homeopathic Association in 2012, where the consultation process led by NHS England that led to this decision to include homeopathy in the list of items that should not be routinely prescribed was challenged by the British Homeopathic Association. That decision, there were two judicial review challenges which were heard, where the lawfulness and rationality of the decision-making process was challenged. The court, however, ultimately found in the favour of NHS England, ruling that their consultation process was robust and met legal standards. Now, I think a case like that, it's very interesting to think about what it would be like or what would be different if NHS England was not the defendant, but it was the Department of Health and Social Care. I think one first issue which is relevant to point out to all of those attending today is the fact that the department will be led by ministers who will be subject to a significant amount of lobbying on behalf of organisations who want a particular drug to be commissioned, or they want a particular homeopathic treatment to be commissioned, or they want a particular fund made available for particular care pathways. And the original reasons for the Andrew Lansley reforms was to try and reduce the political pressure on NHS decision making in the hope that it could be more evidenced, more scientifically based, and that there would be a sufficient degree of separation to ensure that the approach taken was not meddled by the politics of it. So I think the first big issue is the possibility of a return to more political interference. What do you think, Steve?
Well, yes, political interference, but also potentially democratic pressure. One of the things that, of course, we've had over the last decade or so is real concern about excessive use of judicial review to seek remedies that are essentially political. And perhaps we may see fewer cases needing to be brought because more of the issues can be ventilated in Parliament and more robust, arguably, decisions will then be taken off the back of political pressure. Whereas when NHS England had responsibility for all of these decisions, very difficult for interest groups to affect lobbying, certainly not in any open way.
Yeah.
So that's the perhaps slightly more positive spin, that actually have more accountability.
Yeah, and actually to pretend that the NHS isn't a political entity and that these decisions don't have political elements to them is to obscure the fact that actually allocation of funds to particular groups will always be influenced by what the public want. I think there's an interesting other question about commissioning, which comes from the significant cuts of staff that are going to take place. Now, NHS England currently has about 16,000 staff. and is much, much, much larger than the Department of Health and Social Care, which only has around 3,000 staff. The headcount across both NHS England and the Department of Health and Social Care is expected to be cut by around 50%, like the headcount cuts at the ICB level, reportedly resulting in about 9,000 job cuts. Now, some of those jobs will be people who will be appraising commissioning decisions, trying to work out how resources should best be allocated, how to make funding decisions at the NHS level. And it could well be that we see a spate of judicial reviews challenging decisions that are made by individuals in a much more resource-constrained environment and who have less resources to be able to spend on adequate consultation than previously. What do you think?
Absolutely agree. A very interesting couple of comments that have come in on the webinar. First of all, an understanding that the department isn't intending to take any commissioning responsibility, but then a suggestion that even if they do, won't it be delegated locally in any event, as NHS England often does. So those are two important points. I would say, though, that I've certainly been involved in cases where NHS England was the relevant commissioner, for example, for very rare conditions, medication that wasn't routinely to be prescribed, exceptional case funding applications. I was involved in at least 2 judicial reviews that went to court involving challenges to those decisions. So someone has to make those decisions for perhaps the most difficult cases. And if that's going to be done locally, then we absolutely end up back in the postcode lottery scenario, don't we? Where you have a range of different decision makers making potentially different decisions. And that, of course, arguably promotes democratic accountability and local decision making, but will hugely frustrate those who get negative decisions, particularly when people in the neighbouring area might have a positive decision. So I don't fancy the chances of the decision makers who have to make any of these very difficult decisions locally avoiding challenge.
Yeah. I think the hope is that having a direct link from the ICBs to the Department of Health and Social Care is that there's more direct alignment between the national policy objective and the ICBs, and that there's a reduction in the postcode lottery issue. But whether that actually leads, or whether the changes actually lead to improved coordination between national policy advice and implementation really remains to be seen.
Can we just put one other point to you, Yasha, at this stage that's come in, which is the 50% reduction in funding for ICBs. Do we think that's going to either necessitate and or result from mergers and larger ICBs? And if it does, do we get away from the whole point of having local commissioning anyway if they become too large?
I think there's an interesting, I don't know the answer to that. I think ICBs will be forced to make a lot of the decisions about how they make those cuts themselves. And therefore the merger question will likely be resolved at local levels according to whether ICBs are willing to take the step to merge with neighbours. Yeah. The hope, in many of the same ways that some of the ongoing devolution work, which is forcing local authorities to come together to determine kind of the mayoral combined authority grouping of which they would be part under the white paper, is that it will force organisations to think about where efficiencies can be obtained, and that the mergers would be natural mergers which would result from actually similarities of regional circumstances where a bigger ICB would make more sense. Yeah. That would be ideal. But I think we'll still end up in a situation where the ICBs are struggling to deliver an enormous burden of work within a funding envelope that simply is verging on inadequate for what they're meant to deliver.
I wouldn't seek to argue against any of that, unfortunately. Do we anticipate a reduction in the number of ICBs, yes or no?
Yes.
Yes, I do as well. Thank you for that question. And do please keep the questions and also comments coming, everyone. I'll just put a comment to you now, Yasha, if I may. A suggestion that the government is making the error of working the wrong way round, making the announcement first without any proper plan being in place. It is quite striking, I think, isn't it, that when you do the research for a talk like this, there's very little recent commentary or announcements. There was this huge flurry of activity on the 13th of March, and then not much since. So is it fair to say that people have been left in limbo
Yeah.
as our commentator suggests. Would you agree?
Yeah, absolutely. I think one of the big potential pitfalls of this type of approach is everyone in the ICBs now know that they're going to be cut by 50%. We know that the NHS England workforce is going to be cut as it gets reintegrated back into the Department of Health and Social Care, even if the department itself grows. Individuals who wanted to leave their jobs anyway may be leaving their jobs. But there will be a lot of people who will be very, very worried about their futures.
Yeah.
And what happened in the reforms in 2012, and my understanding is also applied now, is that there is an entitlement to redundancy pay, but that entitlement to redundancy pay does not apply in the event that you get rehired by the NHS within 3 months of taking redundancy.
Right.
And the consequences of that potentially are significant costs to the public purse of making individuals redundant, realizing that their job function was absolutely mission critical, and then rehiring them 3 months down the line. So I think one of the things that is quite complex in the planning and almost, takes us to the situation across the pond with Doge doing what Doge wants to do, and then realizing actually that they may well be cutting things that are absolutely essential to the proper and smooth functioning of education in the American example, but here in the health services, is that if the rush to cut leads to the axing of functions, which is subsequently revealed to be fundamental,
You've just wasted a lot of money.
You've just wasted a lot of money. And also you have employment claims coming out of that. You have all of the kind of irrationality decision-making claims, which may well come out of that. I don't know if you can foresee some of those areas where there could be more litigation.
Absolutely. And of course, as lawyers, our mind turns to litigation as one of our key areas of thinking. But I did just want to pause and think about the fact that there are lots of real people involved in this as well.
Yeah.
And whatever you make of the virtues or otherwise of the reform, the way it was announced and the fact that so much of it came as a shock to NHS England staff, I think is clearly wrong in my view, and that there does need to be greater collaboration with the system that you're trying to change. On that point, on the thinking that essentially there's nothing new under the sun and all we do is go around the houses on these reforms, are we going to end up just essentially back with strategic health authorities? Is that how it's going to end up looking, with kind of regional bodies which try and square the local, national servants, you think?
It could well be that, but as ever in politics, you always end up with a we can't repeat the names of the past.
Yes, you have to call it something else.
You have to call it something else and show that it's evolutionary and show that it's something new. So yes, we may well end up, and I think that quite a lot of the online commentary, although a lot of people who are commentators are as in the dark as we are about the precise contours of how this is going to look, have said, look, this looks like it's heading towards the Strategic Health Authorities territory.
Yeah, absolutely. And a very powerful comment has come in about the cycle of stress and pressure as well, the transfer from multiple CCGs into ICBs, that process being exhausting. Now another huge programme of reform. And linking back to your point about litigation, of course, as the local NHS is reformed in this way, that tends to promote the opportunity to litigate in the sense of variable quality of decision making.
Yes.
Doesn't it? And new entities needing new legal advice, perhaps not understanding some fundamental principles, for example, in relation to consultation, and running the risk of getting it wrong. So these huge upheavals, not only incredibly challenging for the workforce, but also potentially increasing litigation risk for the NHS, I would suggest.
Yeah, I would agree with that. I think the original introduction of the 2012 Health and Social Care Act was to try and decentralise decision-making and promote competition amongst healthcare providers. And the decentralisation point was not achieved because NHS England kind of became its own centralised behemoth that sat alongside the Department of Health and Social Care. And I think decentralisation is the hope. But what is complicated for those in ICBs is that obviously that decentralisation taking place at a point in time when their exact future is unclear. And there's yet another round of institutional churn, which I don't want to dwell on too much because it is just a perpetual complaint for those working in organisations that that their organisational structure changes and they have to deal with that.
Yes.
And those changes and the implication of those changes for staffing and management, rather than getting on with the day job, means that the next 2 years may well be a very, very difficult crunch time for people in the NHS, where the organisational flux actually supersedes the kind of improvement of quality for patients whilst it's ongoing.
Absolutely. So a very helpful point of clarification's come in. And I honestly hadn't seen this distinction drawn in the coverage, which is interesting in itself, that it's important to distinguish between the announced plans to cut 50% of the running costs of ICBs, not the overall very much larger budget for programme costs, which of course will be the services they commission. I had hoped that that was the distinction, but I hadn't seen it spelt out before. The question then, or the rather leading suggestion that's then helpfully put is, well, is that potentially counterproductive? Can you actually continue to deliver an effective service with half of your budget to actually run the organisation? And the answer to that must be potentially not, must it?
Potentially not. I think the hope is mergers amongst ICBs, achievement of financial efficiencies through back office functions being commissioned and procured in a way which allows for economies of scale.
Mm-hmm.
Reduction in bureaucratic layers if you have fewer ICBs delivering services, and a more streamlined interaction with DHSC because you don't have this middleman NHS England intervening between the two levels and causing additional friction. But whether any of that works in practice ultimately will depend on the amount of thought and the quality of transformation that takes place.
Yeah.
And that will involve, and I'm fortunately not in the position of being one of many NHS managers who do an extraordinary job of holding it together, bringing all of the workforce along with everybody. And in circumstances where many people will be losing valued colleagues or taking on job functions that are much larger than they previously had, because where there were previously 2 people doing one job, there's now only one. That may well be very, very difficult. And I don't envy those who are kind of in the management roles and executive roles trying to make this work.
Absolutely. My mind is taken to an area of service reform that I'm unhappily familiar with, which is the failure, as we must now call it, of the reforms to special educational needs in the Children and Families Act from 2014. And it seems to me that a very substantial reason for the failure of those reforms to deliver effective provision for children with special educational needs is that system reform was introduced at a time of austerity and at a time of declining budgets. And isn't there now sufficient evidence, he says, asking a hugely leading question, that trying to reform systems and cut funding at the same time is something of a fool's errand, that it's almost impossible to achieve good outcomes if you're trying to reform a system where budgets are being reduced at the same time?
Yeah, I think prior to doing this job, I was a civil servant, and the theme of a civil service conference I was at in 2013 was doing more with less. And there were quite a few people who turned up who said, look, that's a paradox. Yeah. You can do more, potentially more efficiently with the same amount, or potentially you can do more with more. But is it ever possible to do more with less? And I think this government is hanging quite a lot of its hopes on technological revolution. And I think the big question there is AI may well be absolutely transforming diagnostic technologies, but does it ensure that for the patient on the ground, that there is an improvement if care delivery and more seamless service provision and better allocation of resources to individuals, such that kind of appointments allow for more fulfilling interactions with doctors and waiting times go down. All of those things will depend on the quality of the transformation and whether, in the face of cuts, absolutely core services can be provided and really sensible thought can be given to what the wasteful functions are. I think there's some difficulty, and I'd be interested in your view on this, Steve, in identifying exactly what people are doing in NHS England that the government would define as actually being a wasteful function that you would want to now just get rid of or scrap entirely.
That is the big question, isn't it? And I've not seen, if anyone on the webinar is aware of the government having pinpointed that there's a particular thing that NHS England does that isn't needed, I'd be very interested if you put it in the Q&A, because I'm not aware of what that would be, and I can't immediately think of something. On that theme about the quality of the reform process, do we think that these changes are likely to achieve the overall aim of ICBs, of course? So the I in ICB was around integration. Are these changes likely to promote integration, cut against integration, or do we just not know because we don't know enough about the detail yet?
Surely in the short term, there'll be less integration because people won't know who their counterparts are in DHSC rather than NHS England.
And potentially locally as well, of course, if there are also reforms going on locally at the same time.
So you would imagine that there will be a period in which there's a bit of backsliding because people are having to readjust to a new format. I think after that, if the disruptions in service delivery are replaced by a system where there is more coherence in who is doing what in respect of policy development, who is doing what in respect of making commissioning decisions, that may well really help to smooth some of the operational work completed by the ICBs. But I can't say that that's likely to be the immediate effect.
Yes, I think that must be right. An interesting point about oversight within the system. So at the moment, NHS England has significant oversight of ICBs. Do we think the removal of NHS England is likely to give ICBs a free hand, or will they feel the dead hand of the central state on them instead? Are we going to see more central government intervention via DHSC?
Probably depends on which decision. I think if you have a reduced workforce at the centre and you don't have the kind of numbers that we see in NHS England, there will be more latitude to ICBs to make decisions at a local area. But we almost come back to the question of, will there be more political interference in specific issues? Because where a specific issue arises at the ICB level over which DHSC has oversight functions, ministers can then intervene and give their views and make their position known. I think it would be foolish to suggest that that didn't sometimes happen with NHS England anyway, but we might see it accentuated in a DHSC-led world.
I would completely agree. I think that the answer to the question about oversight is going to be that it will vary hugely depending on the nature and controversy of the decision and the area of decision. So ICBs may well feel less scrutiny in more routine areas, but much more scrutiny in politically charged areas. It's the logical view, isn't it? But again, we will have to wait and see.
There's also a clarity question for ICBs. The operational interference by politicians often becomes most apparent during crises. And during the COVID-19 pandemic, there were significant instances, for obvious reasons, where political leaders intervened directly in NHS operations, overriding clinical decision-making for public messaging or for political reasons. Now, that shows that NHS England provided more of a buffer for politicians in theory than in practice. But what will also happen, and Steve and I were discussing this just before we came on this webinar, is that it means that there won't be a separate line and kind of two separate entities operating in the course of crises with different messaging. So one case which was brought against NHS England was R. Gardner and Harris, in which two government policies regarding care home admissions during the first wave of the COVID-19 pandemic were found to be unlawful. And in that case, the court found that the Secretary of State failed to consider the risk posed to elderly and vulnerable residents from asymptomatic COVID-19 transmission when implementing these policies. The judgment emphasised that patients admitted to care homes who had not tested negative for COVID-19 should have been isolated for other residents for 14 days to mitigate that risk. But in that case, there was a defence both from NHS England and Public Health England and the Secretary of State for health and social care. And the hope is that the clarity around policies to be adopted from an ICB perspective will be reduced by not having multiple different bodies.
Yes, I was going to make the slightly facetious point that from a claimant perspective, at least you won't have to spend a lot of time working out who you're suing, whether it's NHS England or the Secretary of State. But of course, that doesn't even work because it may be you're suing the Secretary of State or a local NHS body instead now. So we've taken out one layer, but not necessarily removed all the complexity.
And there may well be, I mean, more difficulty for ICBs, given that the level of expertise in an ICB, I would suggest might be lower than in NHS England, because we're going to be losing a lot of people with like very, very deep policy insight.
You just can't replicate that central expertise across a vast number of local areas. You can't do it.
Inevitably, that's impossible, which means that for the functions from NHS England that do get devolved from the ICBs, we might get back to the situation where, unless NHS England manages to exert some command and control over the latitude that ICBs have, we could actually see increased litigation burden on the ICBs as a consequence of them being tasked with making decisions that they don't necessarily have the expertise to be able to make.
An interesting point that's close to my heart: NHS England currently monitors equality issues for workforce and patients. What will happen, do we think, to that function? And the suggestion is, do we think the government might end up reforming the Equality Act? My take on that is probably not, because, well, it will need to be consequentially amended, but the core duties under the Equality Act will simply sit on whoever holds the function. So if NHS England goes, when NHS England goes, if it all went to the Secretary of State, all those functions would simply move across, and so the public sector equality duty, for example, would then bite on the Secretary of State. If there's a more mixed economy and more local functions, then those local bodies will hold those responsibilities as well. And what that then goes to, again, is this idea that we may see more legal challenge, because the quality of the decision making around technical areas like the Equality Act is likely to be more variable at a local level. Would you agree?
Yeah, totally. I was thinking about the equality impact assessments that I've seen conducted by local authorities who are deeply fiscally constrained. And when you look at what local authorities are able to do in terms of education, for example, equality impact assessments, often there'll be pro forma kind of responses where nobody's actually put the thought in.
Yeah.
Not necessarily that they're culpable or at fault for that, but it means that the actual upholding of kind of equalities principles through the process of doing adequate assessment may well suffer as a consequence.
I think that's right. A nice comment that's come in that I think is, again, a good reality check. The NHS England is actually talking about a transformation from analog to digital. That's rather a long way, isn't it, from this idea of maximising use of AI that we're still trying to get out of paper and into the computer age. Is that fair?
Yes, absolutely. Nobody can see on this webinar, but I'm currently 8 months pregnant, and I am in one of the only hospitals in East London that has digital record keeping.
Really?
Yes. So previous to the current hospital that I'm at, I'm going to do a shout out for UCLH. The requirement was to bring in a big paper bundle called the Blue Book of all of your details. And it's extraordinary that appointments are being configured and appointments are being organised and letters are being shared all by post. I mean, it really feels like a very antiquated system in the middle of one of the world's most dynamic cities. It's absurd, basically.
A rather large disjunct between theory and practice then at the moment.
Yeah, absolutely. And I think one of the other things which is quite apparent is that there are digital solutions to make workflows improved for staff on the ground. And then there are digital solutions to advanced healthcare innovations, whether it's kind of detecting cancers or whether it's better radiography. And those those are just very, very, very different things. And I think sometimes some of the sexier stuff is the digital innovation to be able to deal with complex multifactorial diseases, rather than the sitting down saying, how can we make this organisation function better? Yeah,
completely agree. We've had a very astute question, I suggest, about timescales as well. Again, moving away from whether we think any of this is a good idea or not, it's almost certainly going to happen, subject to the vagaries of political fortunes. Is the timescale achievable? October 2025 as an initial step. But the 2-year time frame, do we think?
For legislation, yes.
It is in principle, isn't it, if it was prioritised, which you assume it will be?
Yeah, I think of the government's 5 missions which they set out, reform and solving the NHS issues was one of the 5. So it's absolutely core. And then actually I've got some stats written down here, which is that for nearly 9 in 10 Britons, the NHS is a top 2 issue. So in terms of public pressure to move fast, people care about the NHS alongside the cost of living as some of the most important things for the government to reform. We also have a situation where support for the NHS model remains as high as 9 in 10 Britons support it. So the backdrop is one where people want, well, the government is committed to reforming the NHS, people want the NHS to be reformed, and people care about it as one of their political priorities. So I think in respect of setting the dates for the legislation to facilitate the changes, the 2-year timetable coupled with the legislative majority held by the Labour Party should enable it to go ahead. Whether all of the details that sit under that legislation will be adequately scrutinised and considered, or whether actually quite a lot of it will be left to delegated legislation to resolve, is something which I think remains absolutely unknown. I don't know, can you foresee there being a situation where some of the big decisions are kind of resolved by primary legislation and then there's secondary legislation left to kind of mop up the detail?
Absolutely. We've heard the Attorney General talk about a need to move away from delegated legislation, but it's incredibly difficult for government and parliament to do that in the modern world because of complexity, and to actually include enough of the detail within primary legislation is virtually impossible, particularly where you set yourself a tight time frame, isn't it? I wonder if the bigger question on timing isn't so much will they get the reforms through in 2 years, because that's largely within the government's control, but how long will it take in a best case scenario for them to actually make a difference and be seen by the people who are desperate for the NHS to get better? Because it would seem that system reform is, even in the intended case, going to take a number of years to really evidence the benefit, isn't it, to patients, and how much goodwill will there be to maintain the support for these proposals, assuming there is support, if in fact in the short term they might be making things worse.
Yeah, there's a kind of move fast, break things, transformation imperative that you can almost see behind this. But whether the organisational cultural changes, whether the acceptance of restructuring, especially for a workforce which has undergone so many different top-down changes over the course of the last decades, that there's likely to be a significant amount of institutional resistance, is one of the things that the government's going to have to face. And I think clarity in the form of the 10-year plan, so that everybody knows what the ambition actually is what really, really needs to come from the government to ensure that this isn't just the classic scenario of rearranging the deck chairs on the top of the Titanic.
Absolutely. Well, talking about another important group of deck chairs, if I can continue your analogy, we've talked a lot about ICBs. What do we think the role is going to be for NHS trusts in this brave new world? Where do we see NHS trusts fitting in, given they're in the forefront of healthcare delivery?
Yes, I think. Yeah, I think
is that one of our known unknowns? Do we think?
Yeah, I think it's really, really, really unknown. I think the relationship between the changes and the ongoing 10-year health plan remains unspecified.
Yeah.
What's going to happen in the trusts, you would hope, is the content of the 10-year health plan. And I think in our list of what we don't know, how the new structure will support the delivery of services by trusts is not fully defined, and you would assume that that falls within the set of tasks which are to be resolved by this new body, which is being set up and led by Sir Jim Mackey to oversee the organisational shift.
Yeah.
So the transformation team should hopefully be dealing with that issue, but whether it is actually within that remit, well, that information isn't in the public domain yet.
And do we see any clarity yet about what it will mean for direct providers, people on the ground providing health services?
I think Again, not a lot of clarity. There's been a lot of bids by those who are kind of in the wider healthcare world for what they hope might be achieved. So I came across an article by the BMA chief, Professor Philip Banfield, which suggests that one area of focus could be fixing general practices, with the idea that to date, NHS England has been a reasonable barrier to prevention of contract reform. And that what the government wants to renegotiate is a completely new national GP contract by the end of the Parliament. And if you remove, well, when you remove the middleman, that will simplify contract negotiations. And then you've got the other question about kind of the provision of medical training. That should remain as a central function rather than being devolved. But how does the actual, how does that work in practice? Still unclear. And I think one of the things that the 2-year time frame makes extremely difficult is that it puts a lot of pressure on resolving these organisational issues, which are enormous, within 2 years before the organisational changes have actually been effected.
Yes.
So you might, and that again comes to kind of whether there's going to be increased litigation, whether there's going to be decisions which are challengeable, which is if you're trying to simultaneously solve for a new organisation that you haven't seen iteratively change or be amended in practice, are some of the solutions that are going to be developed for the interaction between ICBs and trusts or for the new deal for GPs not going to have been done in the environment in which they will ultimately sit, and therefore are there going to be some just really, really complicated organisational issues that emerge.
And the need for perhaps yet further reorganisation after the 2 years
Yeah.
as well. So another very helpful couple of interventions come in. So first of all, we're reminded that there's an expectation that trusts are going to save 50% from corporate costs.
Okay.
As well. So yet again, this idea of can we do more with less? And I think we've both expressed adequate scepticism already about that potential. It's certainly going to be a risk, isn't it? And a point that's made about the fact that the 50% reduction in corporate costs for ICBs has to happen by December 25. Yet, of course, the NHS England reforms are on a different time frame because of the need for primary legislation. And there may be changes in NHS England responsibilities that then affect ICBs.
Yes.
How's that going to work? And again, can we say anything more than good point and we don't know?
Yeah, I think the answer has to be good point and we don't know, because if ICBs trim corporate costs by 50% and then the organisation demonstrates that there are some corporate black holes which have emerged,
or they're given
new to pick that up.
Absolutely, or they're given new functions, and then of course those corporate centres may have to expand again, mightn't they?
Yeah, is the transformation team going to be dealing with those issues? Is the transformation team anticipating that? I'm absolutely certain that they will be aware of them, but what kind of information are those working on the ground going to get as this takes place to ensure that they're well enough apprised of all of the developments that they can actually run their organisation smoothly?
Absolutely. So one group we haven't talked about yet who are directly affected by this change, what do we think is going to happen to NHS England's legal function? Do we have any clarity yet about how the lawyers will be affected by this?
Well, cases which are DHSC cases are currently led by GLD lawyers rather than NHS England lawyers. So we anticipate that the cases which are currently led by NHS England specific legal team will probably be transferred to the GLD. One question that might arise from that is whether the specialist knowledge of healthcare law, which sits within NHS England, will be lost because you'll get a more generalist stream of lawyers working for DHSC. I don't know, would be interested to know if anybody who is on the call or is on the webinar is aware of the kind of level of churn of GLD lawyers through different departments to DHSC, or whether there's lots of people who do health law, kind of health law lifers. Whereas for NHS England, you go and practice law for NHS England because you want to be a healthcare lawyer. Yep. So there might be a bit of a loss of specialist expertise there.
You can see that definitely. So we're getting through our questions, which is very good to see. A question that's, I think, very timely and was one that was I was toying with as well. What do we see, if any, being the impact for private providers within the healthcare space? A controversial issue.
Yes. What none of the announcements have said is that the NHS is being privatised, notably. What all of the announcements suggest is that there is a period of churn and change. Whether private providers become the ultimate beneficiary of that because there is a short-term impact in service delivery is unclear, with people moving from getting GP appointments to healthcare checkups from local services and instead paying for private provision. I mean, that may well increase.
Feels to me like it must be the case that these changes are only deliverable with significant innovation.
Mm-hmm.
There's no realistic way that these changes can be implemented successfully by just doing what's done now a bit better.
Mm-hmm.
And therefore, if there's going to need to be radical innovation, that tends to suggest the involvement of the private sector, doesn't it? And I think that's been where a lot of the messaging has come in, that of course no Labour government is going to talk about privatising the NHS, but the involvement of the private sector in delivering innovative services, I think, will be likely to be promoted by all of this.
Yeah. And also, if procurement becomes simpler and negotiations remove the NHS England function, it's quite possible that the procurement arm of DHSC will be quite active in coming years to try and find large-scale digital solutions to try and get the back office streamlined function that everybody is hoping for.
Absolutely.
What that will be done in the face of is a significant civil society amount of resistance of people who are really, really concerned about who is accessing NHS data, what type of NHS data is being accessed, and what is being done with that data and where it's being shared. So I can foresee that if there are significant contracts up for grabs over the course of the next couple of years for very, very large data analytics functions in the NHS, that those will be ones which will be very, very, very closely supervised by those who are concerned about privacy and are concerned about the sharing of personally identifiable information and are concerned about sensitive healthcare data.
Completely agree. And with my local focus, procurement decisions taken locally, again, are more vulnerable to challenge generally because the expertise, the people taking them is likely to be lower in many cases. So there may be an increase in local procurement litigation involving NHS bodies, I would suggest. And
in my personal practice, I've done a reasonable amount of GDPR work for NHS providers, because GDPR is a difficult piece of legislation to comply with. And NHS providers invariably and unfortunately release very sensitive information to the wrong people on occasion. And that's very expensive for the NHS.
Absolutely.
And I think one of the things that you would hope would be part of this reform, if you're thinking about overall how to make sure that you're not just spending lots and lots of money on, bad behaviour and the resolution of bad behaviour, is ensuring that you're not giving entities which aren't able to manage data in compliance with the law the responsibility for doing so.
Absolutely. I'm conscious that we've got about 5 minutes left, Nyasha. Is there anything that you think attendees desperately needs to hear? Is there anything we've missed in the note you've helpfully prepared?
No, I think it's interesting trying to talk about it at this phase of kind of development, because we really, really are at the earliest stage of reform. And so talking about the legal substance of any legislation that might be coming down the tracks is absolutely impossible. But I foresee that this is going to be a really dynamic area over the course of the next 2 years and impacting basically the entire NHS.
Absolutely.
So I hope it ends up being as fruitful as the government, I think, hopes that it can be.
When we may have to come back and have another go once we see, for example, draft legislation. A specific question that's been asked: do we know who the transformation team are of one of the big four accountancy firm has been appointed to lead it. Is this an example of privatisation / outsourcing, or is this a civil servant team as far as we know?
I don't know. Yeah, I'm sure a quick check with Mr. Google might assist that. Invariably, there will probably be some assistance from some private sector organisations, but I know I'm afraid I don't know the answer to that.
I would suggest that this isn't just privatisation by the back door. I think to speak perhaps slightly in defence of what the government are doing here, the Darcy review suggested very strongly that the structures in the NHS were wrong and that the Lansley reforms haven't worked and have actively hindered the development of the kind of modern NHS we'd want. And if you're told that as a government, it's very difficult to know what to do about it other than act.
Yeah.
And of course, to act is going to cause difficulty and challenge in the short to medium term. But equally, would you just invest in an NHS that is structurally flawed in the way that's been identified? It seems to be the problem isn't so much scrapping the Lansley reforms, going back to more political control of the NHS. I was certainly personally and broadly supportive of that. It's trying to do that in a climate where you're then significantly reducing budgets for organisations. It's the combination of the reforms and the cuts that's problematic. Would you agree?
Yeah, I definitely agree with that. I think the paradox that those trying to lead the NHS face is the need for trusts and ICBs to be empowered to respond to local conditions and to have enough competition within the sector that different adaptive responses can flourish. And then hopefully be rolled out across the entire system as examples of best practice. If you have too centralised a system, then ultimately you prevent the types of innovation that we really want and need to see in order to ensure that the NHS is kind of fit for the future. But doing that in a way which doesn't create a postcode lottery, and doing that in a way which ensures that there's adequate oversight and accountability so you don't get a mid-staffs type crisis, which ultimately precipitated the Lansley reforms, is really, really, really nuanced and delicate. And probably the answer sits somewhere different in respect of centralisation versus decentralisation for almost all elements of NHS policy making and decision making, whether it's procurement or commissioning or funding. And the process of working that all out is also a process that zaps time and energy from the front line.
Yeah.
So I think one of the things that I would really want to repeat and amplify from what you were saying is I don't think that the intention here appears to be one to kind of reduce and remove NHS services. It's a government dealing with an absolutely monolithic entity that's in crisis.
Yeah, that's right. At a time where the government have decided that they can't invest vast sums of money into the system. So simply spending their way out of trouble is not an option that they are considering. And
hopefully, and what has been allocated is more funds for some of the frontline services at the same time as the reduction of back office functions. The problem is back office functions support frontline services. And if you don't get it right, there's a huge risk for patients.
Absolutely. Well, in the last minute we have, when do we think we might know more? Is there anything we can tell our attendees about when more information, more of the known unknowns might become known?
Well, we've got the spending review coming up, and there might be more information disclosed then. If not, we might be looking towards the autumn budget.
And the 10-year plan, do we have a date for that?
Those on the call I don't know at the top of my head.
Yeah. So it's a watch this space scenario. We will, I think, look to come back and do this again, perhaps when a little more information is available. Thanks ever so much, everyone, for the really helpful contributions and comments we've had. Thank you, Nyasha, for sharing so many useful insights today. And for all those on the call who are responsible for making all this happen and for achieving good outcomes for patients in the NHS, best of luck. And we wish you all the best in whatever structure we ultimately end up with. Thank you very much, everyone.
Thank you.